Good evening, sir. Sir,
So is Prachi Sathe here?
Good evening, good evening, good evening.
Is Prachi here?
Dr. Prachi for 5 minutes, sir.
Okay.
In the meantime, let me introduce myself first and then we'll go further. I am Dr. Rajiv Joshi. I am from Pune. I am a pediatrician by profession and I have also done LLB as passion. And I am the founder of the Medico Legal Society of India, which was formed in August 2022. And now we have got about 70 members, out of which about 50 are qualified lawyers.
I see.
And
Wow.
MBBS or MD degree, and 20 have taken special training in law, either by attending our courses or by attending some other courses, though they do not
Amazing.
have degree as such.
Amazing. Yeah.
So the basic aim and objective of this association is to work in the area of medical legal aspects which pain all the doctors in general, and maybe some doctors in particular. If there are any individual concerns also, we are happy to help all those people who come to the association, whether they're members or not. However, the main focus of the association is, to start with, we started with PIL in violence against doctors. Then we have filed an intervention application in Kerala High Court for the case which the Kerala Hospital Association had filed in Kerala High Court for various issues. In that, we filed intervention application and we brought to the notice of the High Court that the law in Kerala is so weak that the chances of violence in Kerala are very high. There are no punitive measures. So fortunately for us, the court heard our arguments. They directed the government to hear us, and the government of Kerala was telling us continuously that they will change Act as early as possible. Unfortunately for all of us, Dr. Vandana Das had to lose her life when she was brutally murdered by somebody stabbed her 11 times in chest. But that pulled a trigger, and the court was very furious about the non-inaction by the government. And within 1 week, Kerala government came up with ordinance, and then in 3 to 4 months' time, they have framed the act, which I am proud to say that we have contributed to that act, and that act is the strongest act for violence against doctors in India. That is one of the success stories of Medical Legal Society of India. We have already filed 4 intervention applications in different cases in Supreme Court of India, which are basically related to interns payments, then stipend for interns, then generic drugs. The third one is for this Sunit Upadhyay case, where his wife was suicide and he filed a case. So we are interested in that application to tell the court what guidelines are required, and various other projects which we are taking up. And currently we have filed intervention application in a PIL, suo motu PIL filed by Bombay High Court regarding the deaths of 41 patients in the Nanded Hospital and 13 patients in Sambhajinagar Hospital. Also, we are in the process of filing a intervention application suo motu PIL filed by the Karnataka High Court, in which they have said that there is a deficiency of staff in the healthcare institutions. Now, that is where we stand, and we welcome all of you, all the members who are more interested today in the speech of Dr. Mani with respect to the end-of-life care, what work he has done, phenomenal work he has done by getting a judgment from Supreme Court, and now what he wants to do beyond that. That is what we are about to discuss here. I am still waiting for Dr. Prachi Sathe, but unfortunately, I don't think she is there till now. Just give me a minute. I will call her on phone, and if he is unable for some reason, then we will carry on the program. Please wait for a minute.
Dr. Mani, namaskar. Dr. Vasisht from Gurgaon.
Namaskar. Wonderful. Wonderful meeting you here on this platform.
Wonderful platform. and I was so excited to interact with you after a long time. Post-COVID life and the world has changed.
Yes.
Okay, okay, okay. Dr. Prachi is joining in a minute, so please bear with us for some time. In the meantime, if anybody wants to ask any questions regarding Medical Legal Society, I would be happy to answer, that we won't have time for this discussion at the end. So any suggestions, anybody has any point of public interest which Medical Legal Society should handle, please let me know. We'll take it up.
But you see, unfortunately, violence is not just in Kerala, violence is there everywhere.
Yes, sir.
And have other state governments responded likewise?
We are trying with Madhya Pradesh, we are trying with Karnataka. We have also tried to work with central government, but central government has blatantly told us that we will not make a central act. And the reason that they put forward is something which has some base in constitution, because health is a state subject and law order is also state subject. We tried to argue with them that finally all the doctors all over the country are facing the same problem, and there is no constitutional bar for making a law in this area. But Home Minister has blatantly refused to do any inaction at national level.
Yes, state subject, but it is of concern to the center as well. It can give an opinion, it can give a guidance.
Absolutely.
So it is not exempt. And particularly Maharashtra, you remember there was a boy, young doctor who lost his eye.
Yes, yes.
So, I don't think other states are anyway different from what Kerala was. And so they also deserve the act.
Absolutely. What we could do was compare acts of 21 states and make a comparison table and tell the court that some provisions are there in one state and some provisions are not in one other state. So
provisions are one side. Another side is the provisions are not being utilized or they are not being implemented.
Absolutely, absolutely. The reason
so it amounts to the same thing as not having.
The reason for that, sir, is most of the cases, the accused person says that I did this on the spur of the moment, and then IPC helps him to get acquitted. So we are trying to get the Epidemic Disease Act provisions of presumption.
So if you injure another person at the spur of the moment, are you spared in our law, in IPC?
There are even the murder is spared, sir, in some cases. Unfortunately.
No, not only in self-defense.
No,
if you injure out of anger, you are injured at the spur of the moment. How can any IPC be protective of that person? I mean, there may be mitigation of punishment.
Unfortunately, what happens, sir, the punishment is reduced.
Punishment is not reduced to nothing. It is reduced or mitigated, but it's not disappears.
Yeah.
The thing is, even FIR is not lodged. That is peculiar. It's not admitted.
Yeah. So if you read the Kerala High Court order, what their classical order they have put in is that when there is a report from hospital or a doctor, the FIR has to be filed within 1 hour. This is non-negotiable. That is what the order said. And that is
what is the reality on the ground post the act?
Post act, there are the FIRs are being filed within 1 hour's time in Kerala at least. So
that's what I'm trying to say. You see, when you make the comparisons with other states, you should state clearly how the provisions have been implemented on the ground.
True.
And what are the data thereof? Dr. Prachi is here. Hi.
Yeah.
Hi, Prachi.
Good evening.
So get on with our subject for today. Okay.
Yes, exactly. I'm really sorry. I was a few minutes late.
No, it's not a problem. So I will first introduce Dr. Prachi Sathe, because medical legal people who are here may not be knowing her. So first I will just introduce Dr. Prachi Sathe. Dr. Prachi Sathe has been my friend for about, I would say, 45 to 50 years. And
from college days.
We were in, not only college days, I know her from her school because we were studying rival schools. So she was a brilliant friend. She is a brilliant doctor even now, and she is first person in Pune to have been trained in ICU management. She was trained in UK on international fellowship. Then she came back to India in 1991 and she started a 4-bedded ICU in Pune, which is now 50-bedded ICU, one of the best state-of-the-class hospitals in ICUs in Pune city. She is founder director of this intensive care unit, and she has treated more than 25,000 ICU patients. She is actually first full-time ICU physician intensivist in Pune. She is founder member and vice president of Indian Society of Critical Care Medicine. She is executive member of Critical Care Education, and she is a regular teacher for DNB in Critical Care Medicine. So all these accolades for the work that she has done is phenomenal, and I thank her for participating in organizing this program, and I request her to introduce Dr. Mani. Dr. Prachi Sathe.
Thank you. Thank you so much, Dr. Rajiv Joshi. It has been really my
co-host. And do you want to project any slides so that I would like to make you co-host and you can?
No, I don't want to project any slide. Okay. I'm just going to introduce quickly because we are very keen to listen to Dr. Mani and for his views on this. Okay. So first of all, I thank Dr. Rajiv Joshi not only for inviting me over here, but also taking the lead for forming Medico Legal Society of India. I happen to be a founder member along with him, and I welcome all the members for this very interesting session which we are conducting under Medico Legal Society of India. It is my proud privilege to introduce Dr. R.K. Mani, again whom I know for at least 30 years because both of us have been founder members of Indian Society of Critical Care Medicine. And it has been a number of times that I have approached him for discussion of various issues whenever there were any doubts or any disputes or
Recording in progress.
Yeah. So, Dr. Mani, who is MD, FRCP, FCCP and FICM, currently is the Director of Clinical Services, Pulmonology and Critical Care at Yashoda Hospital, Kausambi, Ghaziabad. His contribution in non-invasive and invasive mechanical ventilation and extracorporeal lung assistance is very well known in critical care medicine. But more than that, right from the beginning, he has been a torchbearer for all the issues related to ethics and end-of-life issues in critical care scenario. So his career is spanning nearly 40 years, and he has helped develop critical care and pulmonology departments in several frontline tertiary hospitals. He has published extensively as a lead author, and he has been a chief editor of Indian Journal of Critical Care Medicine. So I really feel proud that he has worked with ICMR for two major publications. One is about the definition of terms used in end-of-life care and guidelines for DNAR, and also representing the ISCCM. He was appellant in the recent Supreme Court judgment simplifying the procedure for withdrawal and withholding of the life support in terminal illness. So here I present Dr. R.K. Mani to this august audience. Dr. Mani, please.
Thank you for this wonderful opportunity to be with you all. Thank you, Dr. Rajiv Joshi. Thank you, Prachi Sathe. She's been a comrade and friend with the ISCCM and the critical care work. So today we'll talk about EOLC, where we are today and which is the way forward. Yes. So the context is what? The context is foregoing of life support, withdrawal and withholding of excessive, inappropriate or futile interventions, which happens in terminal illness or in illnesses where curative options have got exhausted, and still we carry on as a matter of course. And this has been a bane of modern intensive care. While it's a great blessing, it has made possible to salvage many conditions which we didn't think possible, say a decade or so back even. So it's rapidly evolving, improving. However, there is a subset, irreducible subset, where we cannot win, but we do more harm with interventions than good. And we may sometimes do that over the objections of the patient or the family. We may not consider the best interests of the case. We may just do it as the only default option we know. But world has been changing. World has been changing since the late 80s, 90s in this regard. In fact, the high-income countries are where treatment limitations are more common. You know, that's a paradox. It's the low and middle-income countries which are still sort of caught in a different era. The high-income countries, the surveys show, very published surveys show that 70 to 90% of deaths in the ICUs are through an end-of-life decision or a treatment-limiting decision, which may be withdrawal, withholding, or DNAR. So this graphic shows you, in a nutshell, what we mean by this. Withholding means we don't start an intervention, like mechanical ventilation or dialysis or vasopressor or whatever other intervention, ECMO, we don't start it at all. So that's called withholding. And it's a considered decision not to start it because it doesn't fit well with the prognosis or what is possible for the patient. Or it may be against the wishes of the patient, either expressed before or expressed through the family. Withdrawing means once an intervention has commenced, it's ongoing, you stop because it's going nowhere and you realize very clearly it's not helping, but it's harming, it's only delaying or making death more burdensome and painful. So you have heard of Jean-Louis Vincent, who is one of the doyens of critical care, still leading with a torch. In his opinion and in the opinion of the ethicists of the world, consensus is withholding and withdrawing are at par ethically. And of course, legally also in most of the countries, including ours, withdrawal and withholding are the same. Of course, withdrawal is more daunting to most physicians. When you remove a ventilator, I mean, death seems so proximate that you think you have caused it. But the premise is the same with both, that the disease is making the patient die and you have decided not to intervene. Isn't it? The premise is the same, but it looks different in practice. So many people worry about the legality of withdrawal, but they are less worried about it when they withhold. But technically speaking, they are the same, although in practice, it's a bit more challenging to withdraw. But around the world, I mentioned the high-income countries, withdrawals are as many or more than withholding, unlike in our country. So what do the recent data show us? There are a lot of qualitative studies based on intensive questionnaires, giving case scenarios to the caregivers, doctors and nurses, doctors of various grades of seniority and training. And it's all very clear through a big survey called Apropicus in Europe of about 100 odd ICUs. It's quite clear that 1/3 of patients is judged to be receiving excessive treatment. So that's quite a lot. At least they have this data. In our country, we have not even captured data like this. Excessive treatment means it's disproportionate to what you can achieve. It is unlikely to yield any fruitful result. It's only going to burden the patient more, make dying a worse experience than it is necessary. It's not peaceful. It's not good death. It interferes with the concept of good death, causes a lot of emotional agony and burdens to the family, which they carry over a long period. all that. And even the caregivers, the doctors are not spared. Doctors and nurses also go through moral distress, questioning the wisdom of what they are doing, and sometimes they even want to leave the profession. So if you see, another set of data have emerged in a self-assessment validated questionnaire, so-called the ethical climate. There are various ways in which ethical climate is judged in an ICU, and these are the criteria. Not avoiding decision making at the end of life. Mutual respect within the team. Even the junior most is accorded respect and opinions valued. There's open interdisciplinary reflection, whether overall our treatment plan is appropriate or not. And that happens across specialties. I'm so sorry. And then ethical awareness of what we are doing. It's not just the technical, physiological, pathophysiological judgments, but also ethical judgments, self-reflective physician leadership. That is, a leader is judging whether in the overall context, what the team is doing is correct or it can be improved. An active decision making at the end of life by physicians, all this constitutes an ethical climate, and the ethical climate differs hospital to hospital. There have been studies in USA recently by Curtis. He's no more now, but Randall Curtis is one of the doyens of palliative care in ICU, one of the pioneers. So they categorize the ICUs in the US as those that the default option is a high intensity treatment, and those who have a moderate one, those whose default option is not a high intensity one. So the ethical climate is high in those whose default option is not a high intensity intensive care. So this varies, and accordingly the decision making varies. Accordingly, the quality of death and dying and the quality of the ICU also varies. Involvement of nurses has been included in this ethical climate, and in our country, unfortunately, this awareness is very low. We are not according equal value to our nursing colleagues, and this must change. You see, knowing that we are causing a lot of harm in some of our patients with intensive care when it is excessive and inappropriate. Way back in 2005, the ISCCM sat together. We formed an ethics committee, and some of us sat together. I happened to be, appointed chairman of this committee, and we created an ethics position statement of how we conduct ourselves in end-of-life care and how we manage the patient and the family. So we sort of put it all together coming from our practice. What may we witness to? A lot of people going lama, a lot of people having interventions which were so clearly inappropriate. Even brain-dead people were undergoing LP, for instance, right? Or were advised dialysis, for instance, or some people who had no hope at all were undergoing surgeries. So these sort of things were happening, even craniotomies, right? So we put this down. We need to have, firstly, both objective and subjective assessment and honest and accurate and early disclosure of prognosis. We were holding back a lot, isn't it? If we still do. We either paint a very gloomy picture or we say everything is hunky-dory, but we are not giving an accurate, honest picture of what to expect. then we must offer early, as it becomes clear to us that we are going nowhere, that palliative care and treatment options, DNAR, withholding, withdrawal in that scale of escalating scale of FLST. And then we get into a consensus with the family through conversations. So conversation as an intervention in the ICU, we realized at that point. Until then, we were only thinking about placing lines and vascats and airway management. We realized conversation, talking things over, driving a consensus within the team and with the family is as important, or maybe more important, in having a coordinated approach in the patient management. So when we have a consistent decision, then we implement through proper documentation. So this is what we thought in 2005. Most of these principles hold good today. What we did not have was, there was no legal guidance in the matter. I did go to a Supreme Court lawyer. We scrounged whatever was available. There was no statement. There was just the Beyon core case. There was P. Ratinam case. They were not touching P. Ratinam were touched upon at end of life, but it touched on voluntary euthanasia rather than this sort of situation in the ICU where you want to hold your hand back from interventions which are not going to be useful. That sort of case law did not exist. So after writing this document, with great difficulty, we developed this perhaps over 2 years, and a lot of us had misgivings. So we sent it to peer review for 5 different countries, where people were very advanced in their knowledge of end-of-life care. USA, South Africa, Australia, Belgium, UK, They said it was a wonderful document. This is a humane document, necessary. So then we got the confidence to publish it in our IJCCM as our first guideline. But we had a huge gap. There was a huge hiatus of lack of any even legal recognition of this condition, this situation in medicine. So I went to the Indian Law Commission. Justice Jagannath Rao was there at that time. I persuaded him to look into the matter. And in 6 months' time, he produced the 196th draft bill. A draft bill for the care of the terminally ill patients for the benefit of both patients and doctors. That's what it said. The opening lines were very, very heartening. They said this is not about euthanasia. It's got nothing to do with suicide laws. This is very heartening because everything at that time sounded like euthanasia to people. And it took a long time for us. Still a lot of people believe it's euthanasia, whereas it isn't. It is either not starting or stopping an intervention which is not of use to the patient. So it is decision taken jointly by physicians and the family. What is in the best interest of the patient? It is nothing to do with euthanasia. Even active euthanasia that is practiced in some of the countries is voluntary euthanasia. You can't do any euthanasia in the ICU. Okay? So in any case, even voluntary euthanasia is illegal in India. We accept that. However, the first Law Commission report thought the provision for withdrawal, although it's constitutionally valid, is subject to a lot of misuse. So they were a little scared for procedural guidance, and they thought it had to go through courts. And they thought advance will is subject to misuse. So they said for Indian conditions, advance will is not appropriate. Although these are allowed in most of the countries and they have been allowed for decades without any big reports of misuse. But today, having made bold to practice, as we preached in 2005, we are able to have quality end-of-life care for people. For instance, this patient has advanced cancer and chemotherapy-induced permanent, very poor left ventricular function. So this person did not have many interventions. In fact, his interventions were all stopped and removed. In the 3 months I run up to his end, and look at him now. He's in the ward and with his family, and they're all smiles. So it doesn't have to be a morose, grim, burdensome moment. This is another example of withdrawal. There's an advanced ILD patient, a holy man, aged 102, and he had already been on oxygen therapy for 10 years and fairly bed-bound. He also had a feeding tube, a peg tube. Still, his followers, in the end came, they wanted him in the ICU, and they also requested for mechanical ventilation. I persuaded them against it, had many sessions. They just didn't want to let go. So we had a negotiated settlement. I said, we'll have a time-limited trial for 48 hours. If it doesn't work, then we'll withdraw. So that understanding was there, so we intubated him. There was nothing going, so they themselves came back and said, Doctor, he's going nowhere. Please take him to the ashram, we'll have it removed. So we took him to the ashram and had the ventilator removed with prior analgesia and sedation, anticipatory analgesia sedation. He had a peaceful end, and he could get the ritual that a religious personage is supposed to receive. That is samadhi position at the end of life, which could not have been possible if rigor mortis had set in the hospital. So all this happened in the way it ought to be, So this is what is called a good death, and that culturally varies individually. It's a matter of one's choice. So since then, there have been many consensus standards of care that have been published for end-of-life care. You have worldwide position statements and guidelines, Wellpicus being one of them, and then Indian position statements by ISCCM. There are iterations in 2012. Then another iteration with ISCCM and IAPC, Indian Association of Palliative Care, combined, and there was one Indian Association of Pediatrics also in 2017. There were other publications, FICCI Elicit. Elicit is an advocacy group formed between three professional disciplines: Indian Society of Critical Care Medicine, Indian Association of Palliative Care, and Indian Academy of Neurology. So we formed a task force, combined task force called Elicit, End of Life in India Task Force. The Blue Maple is another big document on end-of-life care, institutional guidelines published by the Manipal Group of Hospital under Dr. Naveen Salins. With ICMR, as Prachi mentioned, we developed the DNAR guidelines, and AIMS in 2020 published their institutional guidelines. And we have been working with the legal group called Vidhi Center for Legal Policy, a legal think tank based out of Delhi, which assists and advises the government on many important legal conundrums. And we have had the benefit of Dhwani Mehta, who is a co-founder of this Vidhi Center, working with us for the last 5 years, with wide consultations around the country. Vidhi Center and Elicit published this model legal framework, which you might find in the public domain. So this is the DNAR, do not attempt resuscitation. One must know very clearly that DNAR does not equal to withdrawal and withholding of other modalities. It is only not doing CPR. So this is the simplest end of the spectrum of treatment limitations, that we refrain from doing CPR for the simple reason that CPR is also has to be medically indicated. It is a success only in a small minority of patients, particularly under the ICU care. CPR successful outcomes are 5% or less. So in the most of the countries, CPR is not being done for critically ill patients because they are already under resuscitation. CPR is only at the point of death. So this is a detailed document setting out the various scenarios in which DNAR decision is taken. And it advises, I was part of the task force which developed this, and it advises how we must, out of respect for autonomy and respect for, out of beneficence and non-maleficence, we need to talk to the family or talk to the patient about CPR and the reasons why they can refuse it. So long legal battles, of course, evolved in the last 2 decades. Aruna Schonborg happened in 2011, 2012. That was the first time the Supreme Court accepted the concept of so-called passive euthanasia. For treatment withdrawal, treatment limitation, they use the term passive euthanasia. It's a confusing term. It's an outdated term and not recommended to use, but then the court knew only that term. It is actually for withdrawal and withholding. So they accepted that passive euthanasia is legally valid, constitutionally acceptable in India, but provided the next of kin or the next friend, in her Aruna Schonborg's case, it was next friend, that is the nurses, provided they agree to it, and that has to be done through the legal process going through the High Court. So unfortunately, like many of these judgments which prescribe an unworkable procedure, nobody could utilize that provision. And they did not, again, following up on the 196 report, they did not recommend advance will. In the meanwhile, in 2006 or 5, there was this Common Cause, an NGO who filed a petition for the recognition of the legal validity of advance will. And I, on behalf of ISCCM, intervened in 2010 because it seemed to all come together. You see, the end of life care advocacy and advance will advocacy, they met at one point of patient autonomy and patient rights in the matter. So that came for hearing, and then we got a success in 2018 with a landmark judgment of Common Cause versus the Union of India, where Justice Deepak Mishra and team, Constitutional Bench, they pronounced that it was legally correct to have advance will and to have the right to refuse treatment, such as, in the form of withdrawal or withholding. They didn't use the word withholding, they used the word refusal, treatment refusal. So any case, at last, on the basis of reinterpretation of the Article 21 in Justice Puttaswamy versus the Union of India judgment of what do you call personal rights, and on the basis of autonomy as an interpretation of Article 21, this judgment was taken together and then made. So it was a big victory, moral victory for us, in the sense that this is what we've been talking about. it was talking, we were talking from the rights point of view. The patient had certain rights of privacy and rights of autonomy, and they are operational in death, and they're operational even when you lost capacity. So you either exercise your right to autonomy directly or through an instrument when you will lose capacity, the advance will, or your family, next of kin, or legal proxy will represent you in protecting your rights of autonomy. In the meanwhile, we all know doctors have to not only respect autonomy, they have to act in benefit.
Mani, are your slides moving?
They will be moving, yeah. They'll be moving, yeah. So this is the petition, yeah. This is the petition because Justice Deepak Mishra's judgment included a procedure. So procedure was 3-tier in making these decisions on the ground. 3-tier means you involve the district collector as a second round where he would sit with another panel of physicians, and then finally the judicial magistrate of the first class. So this 3-tier system was very daunting. It was unworkable the moment we saw it. And again, nobody utilized this provision. That is why we filed a miscellaneous application. Vidhi Center, ISCCM, aided by Vidhi Center. Our advocate was Mr. Datar. So this is for a simplification and clarification. There was a problem with executing an advance will. It has to be countersigned by a magistrate. It's very daunting for many old elderly people. So that was simplified to notarization or a gazetted officer's signature. And then the 3-tier system was simplified to a 2-tier system wherein you did not have to involve the district collector, you did not have to involve the judicial magistrate of the first class. It can all be done by 2 tiers of doctors. One of them has to be impaneled or recognized by the CMO of the district. So this was the victorious day, January 2023, and you can see our advocate Datar. This is Dhwani Mehta from the Vidhi Center. So the miscellaneous application had these sort of simplifications. You can have an advance will executed at any stage and at any age. And it has to be witnessed by 2 independent witnesses, preferably not from the family, but it can be from the family, and attested by a notary or gazetted officer. This is easier, much easier than what it used to be. So the GMFC shall preserve 1 copy, it's deleted. GMFC shall forward 1 copy of the document to the registry of the district court, deleted. So copy of the advance will to the person or person named in the paragraph. So the para 198 and 199 are the ones which are crucial, which set forth all these procedures. So the director copy of this should go to the family members, it should go to the proxies that have been named. You name 1 or more proxies, well, only 1 proxy at a time will be operational. If that first proxy is not available or has died himself, then the next one comes in. So the executor may choose to incorporate their advance directive as a part of their digital health records, or it may be given to a custodian. They call it a custodian that is appointed by the local government or municipal corporation or municipality or panchayat. Now, all these things are not in place from the government side, but this is their advice, okay? All we can do is put it on the electronic or physical records of the hospital, give a copy to your family physician, and give a copy to your legal proxy and family. So we published this, my colleagues in the illicit, Srinagesh Simha and Gursahani and myself, we published soon after this judgment. How does it pan out? So the court says that people, it's applicable to those who have lost capacity. Obviously, who have retained capacity, they can directly tell you. And number two, they are terminally ill. So these are the provisos. So there should be one primary board consisting of 3 physicians of at least 5 years standing. And they call it subject specialist. Now, subject specialist doesn't mean anything. It does mean specialist, right? And usually in an ICU, 2 or more people, 2 or more specialists are anyway involved in the care of the patient. They form the primary board. And primary board has a consensus, and then they put it to the family. And the family also wants any treatment limitation done. You have to get it verified by a secondary board. Secondary medical board. So if there is an AMD, you either follow the AMD, Advanced Medical Board or Medical Directive, or if you have problems with it, then you can work with the proxy. If there's no AMD, again, it's applicable. That is through the next of kin. So that's what the court says. You're supposed to cogitate and discuss. They don't use the word shared decision making. They say you talk to the family, you cogitate. So all this having been done, secondary board, it consists of 1 registered medical practitioner from a permanent panel. You can have from a permanent panel also, or you can have an ad hoc panel. So one of them must be CMO empaneled. It doesn't necessarily have to be from outside the hospital. It can be from within the hospital, provided that one person out of the 3 is empaneled. So this is another mechanism which has to be put in place, because most of the CMOs are not aware of this provision. So we are working that side also to put all this in place. If the secondary medical board, which is supposed to opine within 48 hours, endorses them, then you can go ahead with implementing withdrawal and withholding, sending an intimation or notification to the district magistrate. So this is what it says. See, so far, we've had a lot of problems. In most of the places, you get LAMA. You're not having a properly documented treatment limitation. So we thought, whatever we do, anyway, the doctors are not going to follow. It's not true. When we did an online survey, out of 200 responders, 85% wanted to do them. They felt obliged to do them, but the only thing is they thought legally they were not on sure grounds. So I hope now that it looks a bit more workable, we will be able to establish systems and work within these framework that the Supreme Court has given us. Because LAMA is no answer. It violates every principle. Okay, principles of autonomy, because it's potentially coercive, and it's denotes abandonment by the treating team. It is also puts in place no palliative care efforts. It doesn't work with the family to assuage their feelings. And then LAMA is no protection against legal liability, because Adya Singh et al. Case, Adya Singh versus FMRI Gurgaon, is a 10 crore suit for a young girl who was sent LAMA, and the extubation was done somewhere else or on the way, so that led to a very agonizing death for the child. So we are now developing the 4th iteration of the end-of-life care guidelines along with IAPC. So this is what it looks like now, integrating the medical and the legal framework. So we must have a reflective prognostic assessment. Then we have a consensus within the healthcare professionals. That forms the PMB, Primary Medical Board. Then we have multidisciplinary patient-family meetings, which are not only to set goals of care, but also to provide emotional support and strength to go through these decision-making. And we arrive through a careful process, a shared decision-making. Then we ensure consistency within the team. Then we apply for approval from the secondary medical board. At any stage when there is no consensus, we go back to the drawing board again and then wait for time to assist us for clarity. And then we renegotiate everything. If the assembly does not approve, it is against the request of the family. The families have the scope to go to the High Court for it, for remedy. So we implement. Prior to that, we inform the district judicial magistrate. So we must also continue to address the physical, emotional, spiritual needs of the patient and family, and then provide grief and bereavement support. So I would end by saying that withdrawal or withholding of life support in terminal illness is a standard practice worldwide, and we have been hampered by the absence of clear guidelines from the Supreme Court. And so we have been resorting to LAMA, which is not ethically tenable. So now that the Supreme Court has got a workable solution, we must all make it happen. And the way forward is to create a system by which the CMO can recognize some doctors. You can send some names, as you do for a brain death committee, and have them recognized. Already this is being done in 3 states now. See, in UP I'm doing with the Odisha government. With the Odisha government, pretty advanced stage. It is right with the minister now. We've worked with the principal secretary, health secretary. And similarly, I think we have worked with the health secretary of UP, but it has not reached the minister yet. So we have reached there. Everybody in their respective states should send a copy of this Supreme Court judgment and request that the CMO be apprised of this current ruling by the Supreme Court, and then enable implementation of this process. Thank you all for your patience.
Thank you. Thank you so much, Dr. Mani. It was a very detailed discussion, and that was very useful, I suppose. Obviously, there would be some questions from the audience, and I request them to put them in the chat box. But in the meanwhile, there have been 1 or 2 questions which we have received. Dr. Rajiv, do you want to take it forward?
No, Dr. Prachi, in your WhatsApp, there are some questions, and I already sent you some questions. You can go ahead with the question answer session first.
Yeah.
I will manage the chat box in the meantime.
Yeah, okay. So, Dr. Mani, there could be various situations which we typically come across while practicing in, especially in tertiary ICUs or corporate ICUs. There can be families who are not affording the care. When it goes beyond 1 week, it starts becoming really burdensome, and they are not sure about what to do. And sometimes, how much ever we try to put our severity scores and various assessments, we cannot exactly predict the outcome. For example, septicemia, advanced septicemia, where there could be potential reversibility. So if the relatives are saying that you stop the treatment, we don't want to pay for it, then how is this situation tackled? Can you discuss this scenario, please?
Sure. You see, there are two problems I'll address separately. One is not knowing exactly where we are going, which is a prognostic challenge which we are faced with every day, because majority of the patients fall in the gray area. So how to resolve the gray area? Of course, there are now lots of new data on how to resolve this. In the current guidelines, we will have them all placed, how to prognosticate in a situation like that. When there's a prognostic uncertainty, you buy time, isn't it?
Exactly.
So then you can do the TLT, time limited trials,
Right.
and then you get more clarity, both
Right.
family and yourself. What I'm saying is, lot of the financial problems can be mitigated by appropriateness of our treatment. You cannot take an end of life decision because people have run out of money. That is just not what we are talking about. They have run out of money, then you have to find alternative solutions, right? Either there has to be a mechanism within the hospital, or you have to send the patient in a proper way to a less expensive environment.
Yes.
Now, that is our responsibility to rehabilitate the patient. But when it is very clear that this, even in sepsis, say at the end of 2 weeks, there's going nowhere, and then there is no point in piling on
organ support.
At that time, at least you can take a DNAR decision. Many times, a futile CPR costs them 50,000 rupees. So it's all the more important that we are aware, we are ethically aware of what we are doing, and we take the right decision at the right time. At the same time, not prematurely closing your treatment options because of financial matters.
Right. I think this is very important. And time-limited trials is a good solution, I think, to see whether next 24 hours or 48 hours with our intervention, whether there is any turnaround in the patient's situation. That is true. Now, there is one more question, because when you mentioned, Dr. Mani, you have already worked with Indian Society of Pediatrics also, Indian Academy of Pediatrics, right?
No, they followed our guidelines and they created their own guidelines for pediatrics.
That's right. Means there is a guideline for pediatrics.
Yes.
There is one question from the audience saying that how does the SC judgment apply to children under 18, including neonates?
They have not made any exception. They have not made any exception of any age.
Right.
See, there are situations in neonates and in pediatrics which are terminal, and they are clearly terminal. And they may be less frequent, but they are there. They may not have.
So there is a legal framework.
Chronic illness, yeah.
You
may not have problems of chronic illness, but there are problems of inborn. There are congenital problems. You have anencephaly, for instance, or some other forms of clearly no treatment available situations, and you have advanced conditions which limit their lives or limit their development. So those things exist in pediatrics. That's a separate subject. Of course, what are those clinical scenarios? That's a separate subject. But such scenarios obtain and they are recognized around the world, and there are guidelines for children and neonates as well.
Right. Now, I think you mentioned it very appropriately that in children, or especially in neonates, if they have been resuscitated and put on life support, you are always in doubt about their further development. But we cannot say that at that time, isn't it? Based on that developmental problems, we cannot make a decision of DNR, right?
No, there are some situations which are very clearly hopeless in pediatrics and neonate. That's a separate subject. I'm not an expert on that, but these have been recognized in their guidelines and in the guidelines for children around the world.
Right.
So you can't generalize that for a child they don't apply.
Right.
It's not true.
Right.
That's what I want to say. There are situations there as well.
Yes. Yeah.
Peculiar to that stage. Yeah.
Right. Now there is another question which is interesting, that the patient is at critical stage. We decide to withdraw the treatment, and leave the patient with spontaneous respiration. Spontaneous respiration is present, and the patient is gasping. And relatives ask the patient to be kept in a special room without oxygen support. So is that medico-legally allowed?
That's absolutely fine. Because once the principle is clear that these interventions are not going to help materially, you don't let the patient gasp in the sense that you can control them. Your obligation is two things. You withdraw, at the same time you put in place a palliative care.
With
appropriate, effective palliative care is developed very, very rapidly in our country. Now there are experts available. The expertise in palliative care is growing. So we can utilize all that new information, new skills, and then you can mitigate, you can prepare the family what to expect. That's also a part of the palliative care. And then take care using all the scorings, using all the measurement scales, and appropriately control. You can use sedation, analgesia liberally. Of course, within the prescribed limits. You can use them liberally because it is very clear that even at the risk of hastening, so-called hastening death, you can use them because that is the priority now. Priority is
comfort,
control.
Comfort and pain control. These are very important things. But I think when we are talking about this comfort of the patient as well as the comfort of the family who is watching it, both the aspects are very important. Because sometimes relatives make a bold decision that we don't want to go ahead with advanced or artificial therapies, but then it becomes very painful for them to watch the patient go down. And I think these things also need to be taken care of, isn't it?
Yes, right. We have to talk to the family, be there for them.
Yeah. Now, one very important question here. In medico-legal case like suicide or trauma, patient has reached the hospital, but can we offer end-of-life care in this situation, and whether we can protect ourselves legally in these situations?
Yes, why not? There is no exception made in medico-legal cases. Medico-legal events also involve human beings only. And the human suffering is no different. And the requirements of the dying person is no different. Requirement of the dying patient's family is no different. So I think these are I think we have invented differences. See, medico-legal only means that we are going to be more meticulous about our record keeping and our documentation. It doesn't mean we stop caring for the patient. We care only for the documentation, not at all. Right. Primarily, we have to care for the patient, no different from anybody else.
Right. And it is really very important decision which was given by Supreme Court again, that suicide is not an offense.
No, attempt to suicide is not an offense. By the Mental Diseases Act.
Exactly. So that was very important because till that time it used to be considered so, isn't it?
But abetting to suicide is clearly we are not abetting to any suicide. Okay, by right from 196 report, it's very clear.
Right.
And now also it's very clear by all these judgments.
Right. And you gave an example that now that brainstem death is legally accepted and each hospital has got its own committee for assessing brainstem death and certifying it. Similarly, for this directive also, there should be local committees formed in each hospital, right?
Exactly. EOLC committee.
Would you like to elaborate a bit on this?
You see, even before the judgment, we have had a EOLC committee. We can call it Clinical Ethics Committee also, in contrast to Research Ethics Committee. Okay, you can have 5 or so members. One of them could be a social worker, a non-medical person, and one could be a lawyer of the institution. And you see, the committee oversees now the activities of this kind, the ethical decisions that you take. It could also be a redressal mechanism where the doctors and patients don't see eye to eye, a family. They can have a third party to talk to. So that is quite possible. And now with this judgment, there is a secondary board already. According to the judgment, there is a secondary board anyway. So we can strengthen the system by having a clinical ethics committee additionally for oversight, for quality control and other things.
Right. Thank you. I think you have made a lot of doubts quite clear. The audience is asking, when are you going to keep Dr. Rajiv another lecture for Dr. Mani? Already probably they want to understand few more things and you will take a call on that. So thank you, Dr. Mani. Thanks for sparing your time and throwing light on this important topic.
Thank you.
On behalf of Medical Legal Society of India, I would like to thank Dr. Mani profoundly for giving important lecture on this topic and accepting our invitation for this program. Dr. Mukesh Yadav, do you would you like to say something, Dr. Yadav? Dr. Yadav is our president-elect, sir. You would like to say something?
Again, like to thank Dr. Mani and want to add something to some question asked by Dr. Prachi regarding medico legal. So I think Permanent Katara judgment of 1989 is very much clear about this. Medico legal formality can wait, life cannot. So that is
absolutely, that was a very wise judgment. Yeah. So we must remember that, take heart from that, that you see, that obligation of the physicians is recognized by the court. At least we need to stabilize. We can't make economics as a central point, although it's important. I'm not denying that it's important to run the place. But we know we must have the priorities right. And similarly, in end-of-life decision, this is not an escape route for financial dilemmas. Yeah. It is not an escape route. It's a very serious matter. And I'm not just saying so. I've been working in corporate world, and I have told myself never to take such a decision, and I managed not to. You know, we have been able to be fiscally more efficient. Okay, a lot of the times we are using drugs which are not got good evidence basis, and particularly we waste a lot of money on antibiotics, which are actually an imposition on the patient. It may go do more harm than good. 50% of the pharmacy costs is antibiotics. Yeah. And that is also a bad practice. By reducing bad practices, by being aligned with the best practices, we can be fiscally efficient. We can also have certain compassion systems within the hospital. A lot of hospitals do have. For example, CMC Vellore has a system by which, they assess the capacity to pay, and if it exceeds that, they have funds which they provide. So this has been published as well. You can see, J.V. Peter and others have published how they calculate the capacity to pay and what they do in their system. So these are some things to learn. Like Gangaram Hospital makes them free after some time in the ICU. So they continue care. So these mechanisms we must promote our authorities to introduce. If that is not possible, move to another place and use our network and our capabilities to do so. And this is our responsibility.
Thank you, Dr. Mani.
Okay.
So this judgment or based upon the basic 4 principles of the ethics: autonomy, beneficence, non-maleficence, and justice.
Exactly.
So the best interest of the patient is already written in this judgment also in clarification.
Yes, it is.
Whenever you doubt, you just test what is the best for the patient.
Only thing is now it is our job to put the mechanism in place. Yeah. Now, court can't do everything for you. They've given the directives. Yeah. We have to do the legwork.
Yeah.
Okay. Go to the CMO, go to the magistrate, go to the minister. Once the system is put in place, like our TOA Act, for brain death and organ donation. 1994 came the act. It's not before 1998 that they actually, in a bigger way, they could do organ donation. And now you see there's a huge amount of organ. So we have to allow the mechanisms to sort of take shape on the ground as well.
Yeah, that is where I would like to ask you, Dr. Mani, one question. Is now that you have done some legwork in Uttar Pradesh, so is it possible for you to share certain documents with Medical Legal Society of India so that we can?
This I promise you, we are going to do that. We are working with the Vidi Center, Dhwani Mehta. She will create a template. Okay, how to apply for it. Okay, a template will be created, circulated to everybody, so that they can work with their local.
So we can probably take with all the states or
yes, all the states. Yeah. So we can take up somebody. In each state, somebody can take it up and follow up. We'll give you the template. We'll probably send it to everybody. Yeah.
Please do that so that we can initiate the medical society members to work on it.
Yes, yes.
We can take it forward.
Absolutely. Your society is ideally placed. You've got all the lawyer doctors, doctor lawyers, and then they can take it forward. Yeah.
So that we can bring some uniformity in this aspect. So if you could share some documents with us, we could discuss within the medical legal society also.
Will do.
Brainstorming can be there on this topic.
Will do. 2 or 3 important documents are coming up. One is the end of life care guidelines, ISSM, IPC, the 4th iteration. And that will have all these things detailed, how to prognosticate, how to do it with the new available data. Okay, all that will be integrated. And then you will also have a detailed discussion of the legal position.
Great.
Okay, it's a full detail written by the lawyer. So we'll have full details of all the nuances of the judgment. And then we will also, soon after that, because this is going to be, the manuscript is going to be submitted next week.
Great.
So the publication will come before February.
Yeah, good.
And in January, you will get the template, okay, how to approach the authorities and the states.
I would request all of you to put on your video cameras, because we like to take a picture of all the present people.
That's okay.
Switch on your video.
Very nice audience, very patient. They've been.
We have about 75 people today.
Yeah. Very heartening to see you all and meet with you all. And share what has been a sort of a passion for me for
we are on the first
couple of
screen.
decades.
Switch on your video. Just a minute, because I have to record all of that. So I'll start recording one by one, screen by screen. I'll let you know. I'm moving to screen 2. All of you, please switch on your video cameras. Smile, please. Ajay, Mahesh Sinha, Anand Gadgi, Mohini Paul, Naina Ramchandran, Vandana, Shahina, Devraj Raichur, I think Nipa Patel. All right. Thank you.
Okay.
Thank you, sir.
Okay, thank you all.
Thank you.
Thank you all.
Thank you, Prachi.
Thank you, Dr. Mani. Nice meeting you after a long time.
Yes.
Thank you and good night.
Good night.
Thank you and good night.
Yeah. Thank you, Dr. Prachi Sathe,
Bye. Thanks.
for conducting the program.
It was a really good session. Thanks.
Thank you.
Bye.
So there are some more questions, I believe. Please SMS me your number. Okay, I will do it. I'm sending my number to all in the group. Whosoever wants to take it, please take it. Yeah.
Recording.